Today would be talking on common orthopedic injuries. So as an overview for this lecture, we're going to be going over both injuries that are commonly tested on the USMLE Step 2, as well as COMLEX Level 2, in both adults and children. Some of the common ones in adults are shoulder and hip dislocations, knee injuries, Achilles tendon rupture, and some commonly tested fractures. We'll also go over some fractures in children, nursemaid's elbow, Osgood-Schlatter disease, and Salter-Harris fractures and their classification. So the first section we'll talk about is shoulder dislocations. Anterior dislocations tend to be the most common and are usually caused by a blow to an abducted, externally rotated, and an extended arm. It's important to remember with anterior shoulder dislocations that the axillary nerve is at risk for injury. You may have some weakness in those muscles innervated by the axillary nerve, including the deltoid and the teres minor muscles. Patients will typically present with their arm held in abduction and external rotation. This is important to distinguish between a posterior dislocation, where the patient's arm will be held in adduction with internal rotation. And posterior dislocations tend to be much more rare and can be associated with seizures or electrocutions. Treatment for dislocations of the shoulder includes just a reduction followed by sling, which is going to put that upper extremity in a position of adduction and internal rotation. And then the next slide shows a picture of an anterior shoulder dislocation. You can see the glenohumeral joint there, and the head of the humerus is no longer articulating with that glenohumeral joint. This would be an anterior shoulder dislocation. Some knee injuries that are commonly tested we'll discuss now. Most of these commonly present with knee instability and a hematoma. And then it's important to remember that MRI is the best diagnostic test. As you can see, all these different ligaments with the MRI, as well as the menisci. So the first injury is an ACL injury. These are commonly due to twisting and or hyperextension. Anterior drawer sign and Lockman tests are positive. The anterior drawer test is performed with the patient supine on the table with the hip flexed at about 45 degrees and the knee at 90 degrees. The examiner can sit on the patient's foot to stabilize it, and then the hands are placed on the upper calf and the tibia is firmly pulled forward. Movement of about 5 millimeters or more is considered a positive test. It is important to compare this with the other knee, which would tell you if there is just a general laxity of the ligaments or if it is a true positive test. The Lockman's test is performed with the patient's knee bent 20 to 30 degrees. The examiner's hands grasp the limb over the distal femur and proximal tibia, and then the tibia is pulled forward with the femur stabilized. And again, movement of about 5 millimeters or more indicates a positive test or and is for the ACL tear. ACL injuries can commonly be associated with meniscal tears as well, and the unhappy triad is something to remember. That is typically the ACL, MCL, and the medial meniscus. However, the lateral meniscus tears are more commonly seen in acute ACL injuries. PCL injuries are commonly due to a posteriorly directed force on a flexed knee, such as a smashing into a dashboard in a car accident. And these will have a positive drawer test, which is similar to the anterior drawer test, whereas the tibia is forced posterior, and then 5 millimeters or more would indicate a positive test if that tibia is moving posteriorly in relation to the femur. Meniscal injuries are commonly due to twisting or just a degenerative process, as common in the elderly. Patients may complain of locking or clicking of the knees. Exam is positive for joint line tenderness, and a McMurray's test that is positive. The McMurray test is performed by flexing the patient's hip and knee, and then providing a valgus or varus stress on that knee with internal or external rotation, followed by extension. Any popping or pain would suggest a medial or a lateral meniscus tear. Treatment of knee injuries, typically conservative management, is the mnemonic RICE, which is rest, ice, compression, and elevation. Secondary conservative management includes strengthening, flexibility, and working on endurance. Important to remember, ACLs generally need to be surgically repaired, typically with a graft. PCLs are more responsive to conservative management, although they can be repaired surgically if the patient continues to have chronic instability. Meniscus tears can be either surgical or conservative, depending on the clinical presentation. An Achilles tendon rupture typically is heard with a sudden pop due to a shear stress that is applied when this tendon is already weakened or degenerated. Exam shows limited plantar flexion and pain in the posterior calf with a positive Thompson test. The Thompson test is performed by putting the patient in a prone position and then squeezing the calf muscles. Absence of foot plantar flexion is a sign that could indicate an Achilles tendon rupture. Treatment is a surgical and typically with 6 weeks of casting. Here's some pictures. So the upper picture showing a lack of that definition of that Achilles tendon, indicative of Achilles rupture, and then some images demonstrating an Achilles rupture as well. Colles fracture is commonly due to a fall on an outstretched hand and is a fracture of the distal radius. This is common in elderly that have osteoporosis or also in children. Treatment includes closed reduction unless the fracture is interarticular, and then may require open reduction, and then casting is followed. Here's a couple images of that distal radius fracture or a Colles fracture. Scaphoid fracture is the most commonly fractured carpal bone, and sometimes is challenging to see initially on radiographs. It may take 2 weeks or better. It's important to remember that if there is tenderness in the anatomical snuff box, then that is highly indicative of scaphoid fracture. Avascular necrosis, or AVN, can ensue if the blood supply has been disrupted. That's important to remember with scaphoid fractures. Treatment includes a thumb spica cast and open reduction. This is an image showing a radiograph of a scaphoid fracture. Boxer's fracture is a fracture of the neck of the fifth metacarpal bone, and is commonly due to forward trauma on a closed fist. Treatment of boxer's fracture is a closed reduction with splinting. It may involve percutaneous pinning, or if the skin is broken, an opened fracture in that case would require irrigation, debridement, and antibiotics to prevent any infection. A humerus fracture is commonly due to trauma. The radial nerve may be at risk and may manifest as a wrist drop and a loss of thumb extension. Treatment of a humerus fracture is a hanging arm cast or a coaptation splinting and a sling. Hip fractures are common in patients with osteoporosis. Patients will typically present with a shortened and externally rotated leg. Radiographic Graphically, they may be occult. CT or MRI may be necessary at that point. Distal femoral neck fractures have a risk of avascular necrosis as well. DVTs, or deep vein thrombosis, are commonly associated with hip fractures, and as such, part of the treatment for hip fractures includes anticoagulation, open reduction and internal fixation, and the hemiarthroplasty, depending on the location of the hip fracture. Femoral fractures likely associated with trauma. It's important to remember fat emboli can be associated with femoral fractures due to the large nature of the femur bone, and fat may enter the bloodstream and result in pulmonary embolism. Some common symptoms to watch out for with femoral fractures and associated with this fat emboli include fever, change in mental status, dyspnea, hypoxia, petechiae, and low platelets. Treatment of femoral fractures is commonly intramedullary nailing, and then irrigation and debridement if it's an open fracture, as mentioned previously. Tibial fractures are commonly due to trauma again, and something to be aware of with tibial fractures that can be associated with compartment syndrome. Treatments include casting, intermedullary nailing, and then open reduction and internal fixation. Just a quick note on open fractures as compared with a closed fracture where the skin remains intact. Open fractures are considered an emergency and require urgent irrigation, debridement, and the fracture repair. Risk of infection is high with open fractures, so antibiotics and tetanus are commonly given. Moving on to children's fractures common in children. Clavicle fractures are the most commonly fractured bone in children. They may be related to birth, especially in large infants, and can be associated with brachial nerve palsies. They usually involve the middle third of the clavicle, with the proximal fracture end displaced superiorly due to the pull of the sternocleidomastoid. Treatment includes figure 8 slinging or a typical arm sling. This demonstrates image shows a radiograph of a clavicle fracture showing that medial portion extended superiorly due to that sternocleidomastoid. A green stick fracture is an incomplete fracture involving only one cortex, the cortex of one side, which is the tension side of that bone. Treatment includes reduction with casting and then a repeat x-ray in 10 to 14 days. Torus, or are commonly called buckle fractures, results in buckling of the compression side of the cortex. Commonly the distal radius or ulna. These are likely due to trauma. Casting for 3 to 5 weeks is the treatment. And this radiograph demonstrates that buckle or torus fracture of the distal radius. Supracondylar humeral fractures is the most common pediatric elbow fracture. It tends to occur between 5 and 8 years of age. Proximity to the brachial artery increases the risk of Volkmann's contracture, resulting from compartment syndrome of the forearm. Treatment of these includes casting and percutaneous pinning. Nursemaid's elbow is a radial head subluxation. Typically occurs as a result of being pulled or lifted by the hand. Presents with pain, and the child usually refuses to bend the elbow. These can be manually reduced by gently supination of the elbow at 90 degrees of flexion. No immobilization is typically needed. Osgood-Schlatter disease is related to overuse, apophysitis of the tibial tubercle, pain with quadriceps contraction, commonly seen in young boys that are active in sports. Treatment is typically rest, and then a bracing may be necessary. and this shows that avulsion of that tibial tuberosity. Salter-Harris fractures are fractures of the growth plate in children, and they have or the treatment is usually reduction and immobilization, and then there's 5 different types of Salter-Harris fractures. So a type 1 Salter-Harris is a transverse fracture through the physes, resulting in an increased width of the physes. The growth zone of the physes is usually not injured, and growth disturbance would be uncommon with the type 1. Type 2 is a fracture through the physes and the metaphysis, but the epiphyses is not involved in the injury. The metaphyseal fragment is sometimes called a Thurnston-Holland fragment. May cause minimal shortening, however, the injury rarely results in functional limitations, and this tends to be the most common type of Salter-Harris fracture. Type 3 is a fracture through the physes and the epiphysis. Fracture passes through the hypertrophic layer of the physes and extends to split the physes, inevitably damaging the reproductive layer of the physes. This type of fracture is prone to chronic disability because of the crossing of the physes. However, type 3 fractures rarely result in significant deformity, and therefore they have a relatively favorable prognosis. The type 4 fracture passes through the epiphysis, physes, and the metaphysis. This can result in a chronic disability due to its interarticular nature. And then type 5 is a compression or crush injury of the epiphyseal plate with no associated epiphyseal or metaphyseal fracture. The clinical history is paramount in the diagnosis of this type of fracture, typically associated with an axillary load injury. These injuries tend to have poor functional prognosis. And just as a side note, a way to remember the different types of Salter-Harris fractures is to remember the mnemonic SALTER, which is S-A-L-T-R. S is type 1 for slipped. 2 is A for above the physes. L is lower or below the physes. T is through the physes, and then R is rammed. So that concludes this lecture of common orthopedic injuries. Thank you.